evening. This evening's webinar is Integrating Through Narrative, an introduction to narrative exposure therapy for trauma-focused care. And we are so lucky to have Barry Viljoen presenting for us this evening. We would like to thank you very much for registering to attend tonight's webinar. And we would also like to encourage those of you who aren't PsySSA members yet, or if you are a PsySSA member and you haven't yet renewed your membership, to please do so, or to have a look at our websites and see how we can assist you and how you can get involved in our different structures. I am the chairperson of the Trauma and Violence Division, and one of our aims is to upskill professionals in the field who are working with trauma, because as we know, we live in a country that is filled with trauma and violence, and we often see many patients who experience, whether it be diagnoses as a result of trauma or trauma-based diagnoses. As I mentioned, today's webinar is Integrating Through Narrative, and we will have Barry Viljoen speaking to us. We're so lucky to have Barry. He's worked both in the state sector and the private sector, and he has so many different interests. Some of them I will mention are trauma, working with families and parents with challenges, substance abuse, and also neuropsychology within the correctional and forensic space. And so without further ado, I'm going to hand over to Barry. And this evening we'll have a structure whereby we'll have Barry presenting on some of our theory, some practical, and then we hope to really open the floor for some discussion. Thank you, colleagues. Over to Barry.
Good evening, everyone. How are you? I hope you're well, and I would like to say thank you so much, Lynn, for having me tonight, and thank you, everyone, for joining us. Lynn, can everyone see my screen that I've shared, or is that not coming? Almost I should reshare it.
I think reshare it.
Sure, let me reshare. Just 1 second, please. Right. There we go. That should be coming through. So as Lynn was so kindly saying, my name is Barry Viljoen. I'm a clinical psychologist based in Johannesburg. And welcome all this evening. Well, we're going to talk about something I'm very passionate about and a topic I find incredibly interesting, called the narrative exposure therapy, or NETS. So we'll talk a little bit about it, and hopefully we'll have some time for discussion at the end. I'd love to hear what you all think. Why is it not moving to the next slide for me? All right. So the first thing I want to talk about is the power of narrative. And with that, human beings, we know, naturally understand life through narratives. We create meaning by organizing our experiences into stories. So even if we think about our day, you know, this has happened, then that happened, and here's what it means to me and what's going to happen next. But, as I'm sure many of you will know, trauma interrupts this process. It shatters the continuity. It makes it hard for people to place, you know, traumatic events in their life timeline and to feel as though they have a cohesive sense of who they are. And I think we often see that, especially when we're working with people telling us stories that are very traumatic in what's happened. So at the core of narrative exposure therapy, of course, is the belief that storytelling is healing. And that's important that we're not just talking metaphorically. We're speaking in that regard about how it heals neurologically and psychologically. And of course, within ourselves and within our interpersonal relationships. So narrative exposure therapy helps clients to reclaim their story. So unlike some of the therapies that reintegrate or reframe the past, narrative exposure therapy is focused on constructing a truthful, chronological narrative, and one that doesn't minimize what happened and instead places it in a broader context of the individual's life or the person's life. The approach allows for trauma to become a part of a person's story, but not their whole story, and not defining that who they are. It helps to restore a sense of identity that includes both resilience, survival, and agency. Importantly, storytelling within the therapist with the therapist needs to be that as seen as both compassionate witness and also reinforces the idea that a person's experience is valid, real, and worth telling. And I think that's an important one as well. That regardless of how mundane or embarrassing or frightening it might feel, there's a value to telling your story. And that it's incredibly empowering for those whose voices have been silenced, which we know all too well, unfortunately, is that stories are often told to us in therapeutic rooms and spaces, and then it's never been told anywhere else. And there's a lot of shame and guilt that comes along with that, which is also some of the challenges that are lying in there.
Hi there, Barry. Sorry to just
Yes.
interrupt you.
No,
I
no, no.
see that the slides aren't changing, and some of the our attendees have noticed that.
Okay.
Is there any chance we can just try and
Sure.
reshare on
Let me,
presentation and see if it
sure.
can?
Let me sort that out for you. I apologize. Okay, let's try this one. And let us go.
Sorry, Barry, we're also getting a note that the sound is not great. It's fine on our side, but I'm not sure if you want to maybe drop your camera and then let's see how the sound improves.
Sure, let me try
That
that.
as well.
Let me
I
try
can
that
hear
now.
perfectly on my side. If members can maybe just check their connections.
How's that?
Perfect.
Okay. So, all right. So, and we can all see hopefully as well.
You can go to presenter.
I can go to okay. Technology is an amazing thing when it works for us.
I think just go to slideshow, Barry, and we can take it from there.
Okay. How's that coming for you?
No, it's still not on slideshow. I think we need to say resume slideshow. That's what we're seeing on our side.
Here we go. There we go. I think it's
Oh,
coming
that's
through now.
perfect. That's perfect. Thanks so much.
Perfect. My apologies for that. Right. So we're just talking, this is the recap where we spoke about the power of narrative. Then let's talk about the structure of memories, and especially with trauma. So understanding how trauma affects memory is key to understanding the rationale behind narrative exposure therapy. When someone experiences a traumatic event, the brain's normal memory systems, especially those responsible for the autobiographical memory, can become somewhat overwhelmed. Instead of forming a clear and chronological memory, the experience is often stored in a fragmented way. The sense of impressions, intense emotions, and bodily sensations that aren't well connected to either time nor place. And it's what we call hot memory. And it's often raw, it's reactive, and it's easily triggered. These memories may surface later as flashbacks, nightmares, or intrusive thoughts. But because they're not fully integrated, the brain can't properly file them, if you will, or put them away, and leads to an ongoing and continuous distress. What narrative exposure therapy addresses this problem directly through a structured narrative exposure where the individual is guided to revisit these traumatic memories in a chronological order by retelling the story in detail and anchoring it in a broader life narrative. Narrative exposure therapy helps to reprocess these raw memories, which are fragmented into cold memory, meaning that they become organized, contextualized, and less emotionally overwhelming. The process not only helps to reduce symptoms like hyperarousal and/or dissociation, but also supports to reconstruct or the reconstruction of a coherent self-narrative, which is essential for the emotional healing and identity attached to that. And of course, we know that it's working with the trauma network as well. So the question, what is narrative exposure therapy? A very simply put, narrative exposure therapy, or NETS, is an evidence-based psychotherapeutic technique that was specifically designed to treat individuals who have experienced repeated or prolonged trauma. We often find and refer to work as complex trauma. Unlike trauma therapies that focus on single traumatic incidents, NETS acknowledges that many people, particularly in high conflict zones, or those with histories of abuse, have experienced multiple and often overlapping traumatic events. Um, it draws upon, obviously, cognitive behavioral therapy techniques, such as exposure, but also incorporates areas or elements of storytelling and narrative construction, which makes it unique. And the process is both structured and flexible, allowing for it to be effective even in culturally diverse and resource-limited settings. And we'll touch a little bit on that when we speak about the history of NETS and where NETS actually came from. So when we're speaking about the history of NETS, it first came around in 2002, and it was referred to then as narrative exposure treatment. It was used for traumatized refugees in a Macedonian refugee camp. And shortly after, it was used in a randomized control or a controlled trial in South Sudan, and then it was called for the first time narrative exposure therapy. However, to date, the largest study was conducted in Uganda in a refugee camp after the genocide in Rwanda. So keep in mind that these are the settings that it was developed for, specifically with trying to meet the needs of people who'd experienced these kinds of severe and ongoing traumas, looking at ways that were both cost-effective, culturally appropriate, and engaging, as well as time-sensitive. So what are the core principles of a narrative exposure therapy? At the heart of narrative exposure therapy is the idea that healing comes through storytelling. And not just any story, but a truthful, coherent, and detailed life narrative. For individuals with complex trauma, their memories often become fragmented, overwhelming, and disconnected from time to the context. Narrative exposure therapy helps to restore these memories to their rightful place within a person's broader life story. One of narrative exposure therapy's foundational principles is what we call narrative exposure, meaning that the individual recounts their life story in a chronological order with a particular emphasis on both the traumatic experiences as well as significant positive or neutral life events. This dual focus helps to place balance on the emotional weight of the narrative and reinforces a sense of identity beyond the trauma. And that's an important one there. So during the process, clients are engaged or encouraged rather to describe each traumatic event in detail, bring it into the conscious awareness within a safe and structured setting. These emotional processes help to reduce the intensity of trauma symptoms over time, including hyperarousal, flashback, and avoidance. Another key principle, which is, I think, one of the key and central aspects of NETS, is the anchoring of memories in time and space. And for many trauma survivors, their memory may feel timeless or frozen. And as we know, Herman spoke about the fact with trauma, is that often trauma will speak about the past in a present tense. In narrative exposure therapy, memories are connected to specific ages, places, and circumstances, which give to them structure and containment. Finally, none of this is possible without the strength of a good therapeutic relationship. The therapist plays an active and empathetic role, witnessing a story, helping the structure of a timeline, and providing emotional safety throughout. Narrative exposure therapy is structured yet flexible as an intervention that can typically unfold over some literature will say 4 sessions. However, it's more commonly 8 to 12 sessions, though this can vary depending on the complexity of the person's trauma history. The first step of therapy is obviously the creation of a timeline or lifeline, the visual and symbolic timeline of the client's life. And this is often done using a piece of string or rope to represent the lifespan. Objects are placed along it, with stones to mark traumatic events, flowers to symbolize positive experiences, and some sticks to represent neutral or challenging non-traumatic moments. The physical representation helps clients to see their life as a whole and to identify a sequence of events. Once the lifeline is created, the individual will begin to tell their story in a chronological order, starting from birth or early childhood. And when they reach each traumatic event, they pause to give a detailed narrative exposure. This means that they revisit the event in a step-by-step, emotionally engaged way, describing what happened, how they felt, and how they responded. This process is not rushed, and it allows for emotional processing and memory and reconciliation. The therapist plays a key role here, not just in listening, but also to documenting the narrative timeline. After each session, the therapist reads back part of what's been written and of the account to the client and provides a sense of continuity, grounding, and validation, while also reinforcing the idea that this story is worth being told and preserved. Another important point there. Towards the end of therapy, the client reviews the full narrative with the therapist, and this final closure session is a powerful opportunity to reflect on self-growth and resilience and the meaning of their experiences, reclaiming a sense of control and authorship over their life story. So what is the structure? And we'll talk a little bit about how all of this looks. What are the structures? What can we expect from the therapy? So we know that narrative exposure therapy is structured and yet flexible. We know that it generally is 8 to 12 sessions, depending on the complexity of the person's trauma. We know that the first step is the lifeline creation and a visual and symbolic timeline of the client's life. And this is often done using a piece of string and rope, like I said, and then bringing all those different factors into it. I think what's incredibly important is that the first thing we need to do is put out the rope or the string or the thread or whatever we'd like to use as the representation, and we find the biggest, brightest, and most visceral flower to put at the start. And that identifies the life of the patient, of the client, and or their life in terms of their birth, because their birth was a fantastic moment. And we know that already is such a difference to that which is experienced by a lot of our clients, our patients who've experienced massive traumatic events where they don't find the world as, their birth as having been a great and meaningful aspect. Right. So then what we need to do, the first thing, once we put it down, is we ask them also to look at what stone. How big a stone? Is the stone big enough? Is it small enough? Do you want a bigger stone? Do you want to put 2 stones? What we can also then start doing with it, once we've got a basic timeline, is to ask them to take a look at it and see if it seems right. To also highlight the fact that even after this last traumatic event, because you assume that the last stone they've put down is the reason that they've come to therapy, is that life continues. And this is also incredibly powerful because I think, as most of us will know with trauma, often trauma makes it feel as though our life stops. It's put on hold. There's no future. It's done. Yet there's so much more to live for going forward. And I think that's an important representation to highlight. Then what we'll start to do is we will actually ask them to name each one. We're not going to start doing too much in terms of exploring it, but rather just, and again, using as many of the cold memories or the cold emotions and aspects as possible of name it. So we write a name next to it. We then write when, how, what, but very factual, avoiding any of those emotive elements that can come with the hot memory. So rather we need to focus on that. So then obviously in the session, after we've done that, I'll often and frequently suggest to take a photo so that we can keep it, so we can track and kind of get an idea of just where things are and how things progress as we move along. And then obviously in the next sessions, we'll start going in a chronological order, starting at their birth, at that great moment, and moving through the highs and the lows. Depending how much resources you have and what you'd like to do, if they want to speak about and mention the death as a stone of a family member, a loved one, someone that they cared deeply about, we can always include a little candle, which we can place on the ground next to it, next to the stone, in commemoration of that loved one that they've lost, which I think is also a very powerful and moving tribute, especially when people haven't had the power or the space to grieve and to mourn and to remember their loved ones. So also what's important here as we move along, and that once we've created these lifelines and we've got an idea of what's going on, we tell the story, like we said, from birth and early childhood, and we go through each traumatic event. We pause and go into a detailed narrative exposure and exploration. And this means we revisit each event step by step, emotionally engaged, describe what happened, how it felt, how they responded, And this process isn't to be rushed. It's important to know that most sessions in nets are aimed at 90 minutes. So they're fairly long sessions, they're intense, and they're hard, but hopefully powerful and give us space to move and empowering. So it allows for the emotional processing as well as the memory consolation, or reconciliation, shall I put it. Therapist plays here a key role, not just in listening. So not just in listening, but also in documenting a narrative in real time. After each session, the therapist reads back the parts of the written account to the client. They provide a sense of continuity, grounding, and validation, and also reinforcing the idea that the story is worth telling, being told, and being preserved. And towards the end of therapy, as we move towards the end, the 8th or the 12th session, or maybe a little bit longer if necessary, the client reviews the full narrative with the therapist. And this final closure session is a powerful opportunity to reflect on growth, resilience, and the meaning of the experiences, and reclaiming thus a sense of control and authorship over their life story, one which we know is often too frequently lost in traumatic events. So this is, I found a very beautiful timeline that was done in Brazil. And I mean, if you're based in Brazil and you have the ocean and the beach, like many of us do in South Africa in some parts, we can draw it. So here you can see very clearly that bright yellow flower is the start of the life. That's when they're born. We then move along the rope to two fairly large rocks next to each other, which we would obviously name, putting a piece of paper of what that event was. We then move to the flowers, two great life events there. We then move to a series of rocks. You can use shells as well. You can use anything as long as it represents what's needed. And you can see then we have more flowers, some more rocks, and the life moves on. And you can see that we'll go through each one, describing it, speaking about it, and making sense of it. So when we're talking about the key concepts in nets, one of the most recognizable tools is obviously the lifeline, which we've highlighted. As mentioned earlier, this is a symbolic representation of our client's life. Physical items, which we've spoken about, flowers for positive memories, stones for traumatic events, sticks maybe for neutral ones, or for difficult and non-traumatic events, are placed along the rope. They're not only anchors in memory and timelines, but also helps the client to see their life contains more than just trauma. Also joy, so much that life has given them. The narrative exposure process involves the client telling their life story in detail, especially during moments of trauma. This requires emotional engagement, but also dual attention, a technique where the client is emotionally connected to the memory while staying grounded in the safety of the present. This reduces dissociation and helps with the emotional processing. A very important therapy is the written narrative or testimony. The therapist who documents the story as it's told, session by session, and will serve for multiple purposes. It creates a tangible record of the client's life. It reads something of a concrete, or sorry, something concrete for review and reflection at the end of the therapeutic process. Repetition is also a key element. This, as the client retells and redefines their story, the emotionally charged association with traumatic memories typically tends to decrease over time and overtelling, as well as fostering a stronger sense of coherence and personal meaning, which is also very important. And finally, the therapist's role is not passive. Rather, they act as an active, compassionate witness, as someone who listens without judgment, affirms the client's story, and creates a safe space for truth-telling. This can be especially healing for those who have stories that have never been heard, believed, or told before. So just an overview, obviously, of what we're talking about. The first is an active chronological reconstruction of the autobiographical episode of memory. The second is to extend your extended exposure to hotspots for the full activation of the fear memory in order to modify the emotional network, as well, and through detailed narration and imagination of the traumatic event. So that's hugely important. These are the kind of steps we're going through the overview. Third is a meaningful linkage and integration of physiological, sensory, cognitive, and emotional responses to one's time, space, and life context. The fourth being the cognitive reevaluation of behavior and patterns, as well as the reinterpretation of the meaning of content through processing of neglect of negative, fearful, and traumatic events, as well as completion and closure. The fifth would be a revisiting of positive life experiences for both mental, emotional support, and to adjust basic assumptions. I hope my internet's now come back. It just said it was being funny. The sixth is regaining one's dignity through satisfaction of the need for acknowledgement through the explicit human rights orientation of testifying, an important one, not only for us psychologically, it's also important for us in terms of human rights as well. Let's speak a little bit. So we've got an idea of just how it works and how we go about setting up nets. I want to speak a little bit about the cultural appropriateness. So a lot of authors will say, considering the oral tradition of shared experience, it's thought to make it culturally sensitive, as well as the fact that it was developed within the African context. Again, that does speak to some ideas, but there are some challenges to that as well. So one of the reasons that narrative exposure therapy has gained such wide use internationally is its inherent cultural adaptability. And I think that's more telling than about a culturally appropriateness. Its structure is both clear and consistent, but the content is deliverable and flexible, making it suitable for diverse populations, including those of non-Western traditional societies, which we know the vast majority of psychological interventions are developed for. A key element is that it enhances its cultural fit to the life within the lifeline exercise. And while stones and flowers are commonly used, practitioners can easily substitute these with culturally more relevant symbols, such as beads, plants, colors, spiritual items, or anything that the person carries a personal or cultural meaning for them. I think also, depending where you work, and a lot of the time this is my experience, or has been my experience, is that I've had to use it and adapt it to very minimalistic settings. So I might have, instead of real flowers, I might have fake flowers, I might have pebbles instead of stones, just for the ease of carry. And we could always look at different things. So the use of the narrative as a central method of healing also makes narrative exposure therapy suitable in cultures where oral storytelling plays a significant role in preserving history, identity, and meaning. And we can already think how that links to the African context and African epistemology and cosmology. Many communities have rich traditions of passing down life stories, and the narrative exposure therapy taps into that natural healing framework. Additionally, narrative exposure therapy allows for trauma to be situated not only in the individual's life, but also within their broader historical, political, and cultural context, which is essential for those who have experienced collective trauma, such as survivors of war, genocide, or other natural disasters and displacements. So you can already hear how it's been influenced by those who's developed before. Importantly, narrative exposure therapy doesn't require clients to adapt to Western psychological language or constructs. Instead, it respects cultural beliefs about suffering, resilience, and healing. And the goal is not to impose in a way. There was a big question about adaptations. So one of the big adaptations is for children. You also get Kidnapped, which is an adapted child-friendly version of Nets, where obviously they will very similarly still construct their story and express their emotions. However, limited studies exist with this version. However, one of the largest ones is with former Ugandan child soldiers, as well as refugee children in Germany, Sri Lanka, Sri Lankan children who've also been affected by war, as well as Rwandan orphans. And children here are asked to describe sensory information, emotions, and physical reactions and thoughts, which are recorded by the therapist. What can be a little bit different in this is obviously the written documentation is still given to the child at the end of therapy. However, it might include illustrations and other creative tasks which need to be completed during the treatment program to aid the child in organizing the memories. Often when they don't have the words, they might play it out physically, and it can become a lot more body and sensory involved in that regard. So prior to the construction of the narrative, children then children participate in a lifeline exercise during which they take different flowers and stones, still very similar to the adult, representing both positive and negative events, and place them on the rope to illustrate two examples where I've worked with some children. And you can see they've started to write, we started saying in 2009. In 2009, X happened, and we then will explore it a bit further. So we've highlighted about reenacting body positions during which children show the therapist the way they're physically positioned or their body during a traumatic experience, how they felt. I felt small, I felt scared, I felt like I was falling away and folding away. And then each of these two latter exercises utilized with a purpose of helping to bring about descriptions and language tied to these events. So that's for children, KidNets. So when we talk about complex PTSD, and this is maybe one of the limitations, because I don't believe anything is foolproof, but Herman, we know, spoke in 1992 about PTSD fit the bill for those who've been severely and sequentially traumatized persons, as well as often those are in relationships interpersonally in terms of care and development, and acknowledging the fact that alterations of affectivity, consciousness, and personality occurred, as well as including difficulties in regulating their emotions, feelings of shame, helplessness, as well as distortions of self, distorted perceptions of perpetrators, interpersonal challenges and difficulties in relating to others, as well as mistrust and distorted value systems. And, I think authors have been very clear that, while there can be a lot of good and a lot of value uh, in nets for this population, also concerns about 4 to 8, even to 12 therapy sessions is still not very long. So while it can be very helpful, it might need to be have augmented approaches to therapy. And we know that those who suffer with complex PTSD will frequently need much longer. Is that even in the longer versions of it, which maybe go up to about 20 sessions and maybe a little bit further, it might need more for these kind of very severe cases. When we speak about efficacy, and I think that's an important one whenever we're talking about evidence-based practice and research. So we need to look at the solid evidence base supporting narrative exposure therapy. Narrative exposure therapy has been extensively researched and shown to be effective across a wide range of populations, especially those suffering, multiple traumas, and those who have experienced prolonged traumatic events as well as other vulnerable groups. Numerous studies, including mega meta-analysis, as well as randomized controlled studies or trials, show that narrative exposure therapy leads to significant reductions in PTSD, anxiety, and depression symptoms. The therapy's structured approach to integrating traumatic memories helps to significantly reduce the emotional impact of these memories, leading to measurable improvements in mental health. In particular, the therapy has shown high efficacy with refugee populations and others exposed to prolonged trauma. One of the key advantages to narrative exposure therapy is the cost effectiveness, which makes it a viable option, especially in low resource settings, spaces like refugee camps or community-based interventions. And this is especially important with the humanitarian organizations where resources and access to high-cost treatments are often very limited. When compared to other trauma therapies, such as CBT or EMDR, narrative exposure therapy has been found to be just as effective and sometimes even more so, particularly in environments where access to traditional therapies may be limited. Narrative exposure therapy's real-world impact in contexts like refugee camps, community health centers, and other crisis zones has been profound. An example is narrative exposure therapy is often being used by humanitarian organizations, and the research is showing that it's highly successful in helping individuals to rebuild their personal narratives and gain a sense of control and coherence in their lives, especially when they've lost that in so many ways, practically. So an important one, because this is a critique that can always come up, is, and we know it's a contentious and debated area in psychology, is what is the possible harm of re-exposure? And we know the fact that it is essential to understand that narrative exposure therapy is not the same as an uncontrolled trauma recall. And while telling the trauma story is at the heart of narrative exposure therapy, doing so without the proper structure and safety measures can actually be harmful. Unstructured or premature re-exposure can lead to prolonged emotional flooding, where the client can become overwhelmed by intense emotions and physiological reactions. For some, this can result in dissociation, panic, or even a worsening of some of those trauma symptoms. And this is why with narrative exposure therapy and/or any trauma-focused therapy, it has to be delivered with extreme care. The structured nature of narrative exposure therapy provides the necessary containment and pacing. It builds in elements that protect the client. So saying it builds in elements that protects the clients, such as starting with the lifeline, working chronologically, and ensuring the client has a strong therapeutic relationship to rely on. Therapists are trained to closely monitor the client's regulation throughout the process and to pause, to ground, or to slow down when necessary in a way that leads to healing. As such, we need to keep in mind that the ultimate goal is not just to revisit the traumatic memories, but to do so safely, with compassion and with purpose, and with the goal, and with the goal that we're not taking trauma away. We're rather trying to make sense of it and to see how we can integrate it into our life narrative and our story. That while not defining us, it is an event which has occurred in our life and has had a space in the shaping. However, how we choose to move forward with it, how we choose to engage with it, is our decision, and our autonomy is central to that. Right, and that brings me to the end of my initial discussion of what I'd like to talk about with narrative exposure therapy. And I was hoping that we can have a discussion. I'd love to hear what your thoughts are, what your ideas are,
So we have some
questions,
questions. We do
concerns.
have some questions, Barry. The one I
Yes.
see here is from, and I do apologize if I say anyone's names incorrectly. I believe it's Janelle Gibson. A person can experience a lot of difficulties in their lives. Do you share what type of experiences you may want them to market first? Also, it could be breakups, but also rape and death. Could a string could be kilometers long. So I might maybe let me just unmute Janelle if she wants to add to that question. Maybe you could. Okay, so Janelle, I've asked you to unmute if you want to add to that.
Can you hear me?
Yes, I can.
Perfect. Yeah, so I'm just wondering, obviously in some people's lives, it becomes, they internalize everything as something that's been quite a challenge or quite a chaotic event in their life, especially if they've got kind of low self-esteem, those kinds of things. And so is there some sense of psychoeducation beforehand to kind of elucidate to what the issue is, or do you just focus more on severe trauma, or do you let the client lead you in terms of what they perceive as trauma in their life? Because I think of clients where I personally have worked with them, and I think like that it would literally be like kilometers long, because every event has been internalized as something traumatic.
So I think that's a fantastic question. I do think it does lead, especially with the lifeline, that's very much patient or client led. And you can have as long a rope as you want. My suggestion is always I mean, if you've got space, right, you can lie it down across the floor. You can make a lot of space. You can take a lot of space with that. And to have that they can look at all the stones, all the flowers. The only thing that I guide with, and I explain what it is that the biggest flower, and I normally put that one aside, is this is when you were born, and highlight strongly that you being born was a great and life-changing and meaningful event. And then they can choose any rock, any stone. Often you want to try and have bigger ones and smaller ones. So maybe something that is smaller, innocuous for them. They'll use a little stone. And then a big thing, like you were saying, something that they feel is very traumatic. And that's also up to them. A breakup, if that is the most traumatic thing in their life, 100%. They can take the biggest rock they want. I mean, if you want to find a brick, you can even ask them, make it a bit playful, I think. That sometimes they're like, yo, this one stone is not enough. Well, let's add some more. And if they're like, how big a thing do we need? So yeah, it can be a lot of things. And I think that's why it's also so important, because you can take a photo to document it. You can even ask them if they want to take a photo if they have a phone. And then, as you move along, you can always restructure it. And you can always say, actually, going through my life story, like you said, I internalize things. That thing I had as a brick, actually, I don't think it's that big. I think this other thing in my life is a brick. That's actually a pebble. Or maybe it's a smaller stone.
Okay.
Okay, thank you. I see that
Does
there
that help?
were
Yeah, thank you. I don't know if you can still hear me, but thank you. Yes.
perfect.
No,
I'm going to try go in order, and I see there was a really interesting one from Floris. So Floris, I'm going to allow you to talk, but I'm just going to read it out. It says, Barry, seeing that the net was developed and validated in severe traumatic environments such as war, etc., what kind of clients do you use it on here in South Africa? And so, Floris, I will invite you to talk if you'd like.
Thank you. Yeah, it's very interesting, the embodiment part of the materials you use. So I like the materials that is used in this process. So I was just thinking, in South Africa, seeing that this process is validated in high traumatic environments, where in South Africa are you using it, or with what population? I can see the children as well, if they come out of a school situation where something dramatically took place. But where do you use it in South Africa?
Thanks so much. So I think you're highlighting one of the critiques of it is the fact that so it's a Chinese study which also speaks about that, saying environments, how does it work in quote unquote normative spaces? And what the literature is showing at the moment is actually it's still quite effective. It's easy to engage with, and again, all of us who've experienced some kind of trauma often can have issues with where we have fragmentation occurring. So I've used it with people in correctional services. I've used it with people in community clinics, and actually one or two in private practice where they'd had multiple traumas throughout their life, and just felt like their life was quote unquote a trauma. And I found the lifeline exercise is just so powerful for anyone who's stuck in a traumatic event or has experienced a massive traumatic event, that you can just kind of map your life out and get a sense of just what's happened. And also, just the fact that you've overcome things, you have resilience that can be highlighted. So perhaps there is one study at the moment, I know that's happening in the Western Cape, specifically with children who have come from or have grown up and live in environments where there's high crime rates and high gangsterisms. But I'm pretty sure there are a couple of other interesting applications. I know University of Pretoria students the one year did it at one of their clinics placements, and they found that quite helpful. Just a very different way of engaging with therapy. But yeah, it's a valid point. It's a good question. And I suppose as literature starts to develop, hopefully we'll start to see it in less kind of severe war scenarios.
Well, thank you very much. So what you're saying is a disintegrated person who went through whatever trauma or multiple traumas, one can use it as a therapeutic method individually or then in groups.
Yeah. Look, there is work with it in groups. I'm more comfortable doing it individually because I think it is such a personalized experience of telling your life story.
Yeah, no, I've got experience where we use the Lifeline also in groups, and it worked extremely well in groups, even especially the sharing of the highs and the lows, or as you would put it, the flowers and the sticks. And people start realizing that they're not alone having those feelings and having those traumatic reactions. So it worked very well in groups as well. But it's great to hear the different of using the Lifeline as the objects, because I think it's very important to use objects and not just talk through it, because that embodiment of using those objects and placing them in a specific space is very important to bring that body embodiment into the process of healing. No, thank you very much, Barry. Very interesting.
No, thank you, Floris. That's also a really interesting thing to think about with the groups. I appreciate that. I must maybe look up more and we must speak more about that at some point.
Hey, and
Sure.
I think that
Thanks.
that was a good discussion in answering. We received a question regarding whether it can be adapted to a group setting by an anonymous attendee. The next question that I'm going to put to you, Barry, was one asked by quite a few people. And it's basically asking how can this technique be used in different populations that experience work-related trauma, like emergency medical services, forensic staff, the military, SAPs, Metro Police, health practitioners. And then I see that it was Dr. Hussein who asked if it could be used with grief.
So, yeah, I mean, those are all fantastic questions. Thank you so much, everyone, for who's asked them. Look, I suppose with grief, it makes sense. It can probably mobilize. I don't think it's not designed. Sorry, I see the internet went a bit wonky there again. It's not designed specifically for grief, but I think it can definitely have value to it. When you're talking about with the military, enforcement personnel, SAPs, Metro Police, and healthcare professionals, I think again, it's about how we've made sense of our lives. And I think in all those settings, there are so many compounded traumas and exposure to really, really difficult events. And I think often those can all become compounded into one big thing. And I think if nothing else, it can just help us to help them to see how life looks, which ones they're struggling with. And I know someone else was speaking about flashbacks as well. And I mean, just to help to kind of see which event is the one that's causing the flashbacks and just to slowly break down the intensity of that and move and break down the association between those memories and the kind of the hot memories and to bring it down into a bit more of a cold space, to use those terms, changing the trauma network a little. When I bought some
Okay. Barry, are you there? I think we might have lost Barry for a few moments. I do see the question from Claire, and I think that's quite a useful question. As soon as Barry rejoins us, I'll ask for him to cover this question. And that is regarding how this modality would work when addressing one loss or trauma, given that her work is limited to 6 sessions. And how could it be used to directively address one issue? We still have some time, so I do encourage you to keep the questions coming. As soon as Barry is back on, we'll have.
Sorry, my apologies. I got kicked off
go.
there. I'm not sure if I said
Okay.
something wrong.
No.
I'm playing.
So I think it is a very useful question. And I think it can be joined with the question by, and I'm sorry if I say your name wrong, Meridian. But the question was from Claire, how would this modality work when addressing only one loss or trauma when you are limited to 6 sessions? Could you use it to directively address one specific issue? And then there was, joining on that, seeing as though it requires 8 to 12 sessions, how do you work with patients or clients who can only afford fewer sessions?
Look, I think maybe going back to one of the previous questions, is this has been developed for individuals who've experienced quite extreme trauma. So I think, you know, if you just had one major traumatic event, this is a great tool still, and you probably won't need that many sessions. You'll probably only need 2, 3, maybe 4 sessions. And that's where you'll see in the literature that it's much quicker. It's much quicker. So, you know, obviously the 8 to 12 are the longer cases, you know, or the more extreme ones. So again, if it's just one event, and when I say just one, I'm not taking anything away from, you know, the trauma that can be attached to a single event, but then one also has one trauma to retell, maybe small little stories of challenges and adversities that build up to that moment, but in the same light, great moments, happy moments, and positive kind of anchorings to help them to gain that resilience, as well as seeing that life continues beyond this traumatic event.
Okay. An interesting one posed by both Tara Duplessis and I think earlier on by Anzela. And what they're asking is, can you clarify whether you move through the entire lifetime until present in each session and then repeat this each time? Or do you allow the client to record a few, but not all events, and then pick up from there in the next session?
So that's a fantastic question, and I think it's definitely going to depend about your clinical judgment with regards to how many intense emotions there are, or intense memories there are to work through, and the pace. Because again, you don't want to overwhelm someone, and you want to also give justice to each. So you would start normally at the beginning of the timeline and try and work through as much as you can, right? Obviously, you don't want to leave something that's raw and uncontained. So, you know, you could go through, in theory, in those 90 minutes, the entire timeline, but you might also only be able to get through the first kind of 4 stones, and then have to kind of pause it of, okay, next week we can pick, or the next session we'll pick up on point. You know, you might want to go through the ones that they've already gone through, which now maybe are less of a thing, and then kind of build into the next ones. But again, I think that's the flexibility of, you know, if you've got a massive stone that they are just so overwhelmed with, you're going to spend a lot of time. You might spend 90 minutes in that one story.
Yeah. And a question from Quaid was, if a patient gets triggered during a session, would it impact the whole outline for the next approach? Will you need to restart this approach? And if not, must you adopt a different approach or reevaluate the strategy of the approach?
So I suppose it depends which part they're saying they're getting triggered. Is it the telling of the story that is just quite powerful? And I think one has to obviously approach that with empathy, highlighting the fact that it's really hard to tell the story. You know, kind of say, well, let's go with the detail that you can. How much of the story can you tell? Let's go back, maybe let's just breathe, let's use grounding exercises of breathing. Let's, let's go and look at, your life does continue after this. Obviously this is a big event, and, kind of really working there and anchoring. I don't think it means to throw it away as such, but rather just to kind of work on your pacing. And I think we often have to do that in therapy, if sometimes we're moving too fast or too slow for a client.
Thank you for that. And I think we can maybe take one more whilst our colleagues fill out their CPD form. And possibly, let me just have a look. So just a comment from Venetia. She says, I believe this could be a wonderful way in which to help young children process what has happened for those who have been neglected or removed from their biological homes, especially for them to process emotions and feelings and allow them to release some of the guilt they feel through the storytelling. Thank you for that, Venetia. And then a really interesting one from Snotile and Tembu. How effective would NET be for our suicidal clients who can't seem to find any value in their life?
Sure. So I think that is always going to be a tricky one. And I say this to always be cautious and to evaluate suicidal risk. I think it can be very powerful in seeing that life continues. So with most of the patients or clients I've seen who have been suicidal after a traumatic event, a lot of the time it's because they feel that their life has ended. And my experience has been that the continuation of the lifeline beyond this moment has been quite empowering and powerful for them, sometimes a little bit overwhelming. In that, I also think it's always important to thoroughly screen for suicidal risk and to keep that at the forefront of just being aware of risk assessment, as we should always with any client. To my knowledge, there's nothing that's been written specifically about the efficacy of suicidality. However, if suicidality is driven by trauma, and a lot of the overwhelming aspects of trauma is negated, or is not, maybe not negated, but is relieved to some extent through the process, I think it can have benefits. But yeah, I would always just be cautious. Sorry, I know I'm harping there. I know Nadine Lowe has asked for us for me to share the Western Cape study. I will happily do that with you. Yeah, I don't know if I've answered everyone's question. If there's anything else I haven't gotten to.
I do see one by Jacques, and he thanks you for your presentation and just mentions that in his view, the narrative method greatly assists in helping the amygdala to know the difference between a threat then and a threat now. And he thanks you for your insight. And there
Thanks,
have
Jacques. Always a pleasure.
requests just for further reading resources and any other materials. And if you do have access to that, we will make that available after the session.
So I see Susanna Nell has also raised a hand.
Okay, let me just go to that. Susanna. Can't seem to, oh, there we go. Yes, Susanna, Susanna now. You can talk if you would like to make a comment or last questions before we close up this evening. Okay, I see Susanna said that she pressed the wrong meeting,
Okay.
Okay, thank you everyone for joining us this evening. And from the Trauma and Violence Division, we'd like to thank Barry for his insight. We hope that you've learned a lot this evening. I certainly have. And in terms of working with, traumatized populations, I think a lot of us could learn a lot, especially those of us working in states systems and in environments where there's a lot of violence. Please make sure that you complete the CPD evaluation form. That is how you will get your CPD points. And as mentioned, we will provide resources and we will provide the recording following today's session. Thank you so much to everyone for joining, and have a wonderful evening.
Thank you so much. Have a great evening, everyone. Stay well.